Good afternoon and welcome to the September Learning Forum. I'll turn it over to Carrie to get us started.
Good afternoon, everyone. Thank you so much for taking time out of your day to join us. I'm always so grateful to see all the names and faces on our call. So with that being said, just like Tiffany mentioned, please make sure you put your name and your agency or facility in the chat, and we'll get going. If you haven't already, I can't emphasize this enough. We would love for you to go ahead and get registered for our October 22nd fall conference. There's the link right there at the bottom, or you can capture the QR code and register that way. We have two fantastic speakers who are going to talk about some requested information on sepsis, as well as our important health equity that needs to be discussed. So and please know that that will take the place of a learning forum for October. Next slide, please. Keep going. Some topics that we want to carry over from August. We're going to keep this short and sweet because we have a lot to cover today. But if you haven't already accessed the pregnancy and postpartum immunization card, this is a great resource to have for your facility, and the links will be included when Tiffany sends the slides out after our forum today. So please feel free to access that. Next slide. And then probably one of the most important things I want to make sure everyone is aware of is that effective September 30th, which is just Monday, a major change is happening to our hepatitis B vaccine in all hospitals. We've mentioned this before, but can't emphasize enough how important it is that awareness is out there that the free Hep B program will be ending, and hospitals are responsible for either enrolling in the Vaccines for Children program and also maintaining a private insurance supply at your facility of the hepatitis B vaccine. So if you have any information, Jill's going to post Rachel Samples information in the chat box, and Rachel's with our immunization department for KDHE. And it would be great to touch base with her and just make sure that your facility is on top of this, since it's right around the corner. Next slide, please. Okay, October is also right around the corner, and with that comes the wrap up of our very big FTI AIM bundle that we've been working on. So for all of my FTI champs that are on, if you have not reached out to Tara or myself to let me know the completion status of your facility with each of the components, please do so. Just send us an email, either one of us, and we will make sure that the spreadsheet and data information is accessed. You are not entering data in QHI, so don't worry about going into that. Just send your information directly to one of us. We'll make sure that that gets updated. Next slide, please. I am so excited to be able to introduce our two speakers for today. We are fortunate enough to have both Dr. Kayla Malouf and Hilai Hassas from Sanofi to give us great information about vaccinations. So Dr. Kayla Malouf is a board-certified pediatrician and a fellow of the American Academy of Pediatrics. She's currently serving as an assistant professor in the Department of Pediatrics at the University of Kansas Medical Center. She's dedicated to educating the next generation of medical professionals, teaching both medical students and residents. In addition to her academic role, Dr. Malouf maintains a thriving clinical practice that serves the urban core of Kansas City, Kansas. She earned her medical degree and completed her residency training at the University of Kansas, further enhancing her education with a graduate certificate in public health from the University of Missouri. As a certified professional coach within her department, Dr. Malouf is passionate about supporting her colleagues and fostering a collaborative learning environment. And she is honored to be here today to discuss the important topic of neonatal immunizations. We are super grateful to have her. And then also joining us is Hilai Hassas from Sanofi. She earned her Doctor of Pharmacy degree from Massachusetts College of Pharmacy and Health Sciences. After earning her PharmD, she joined Walgreens as both a staff and specialty pharmacist. At Walgreens, she worked primarily with specialty fertility medications and counseling patients on appropriate administration. In 2019, she transitioned her career by taking a position as a clinical research pharmacist and pharmacist in charge at the St. Louis University Center for Vaccine Department. While there, she established and maintained strong peer-to-peer relationships with highly influential clinicians, researchers, and opinion leaders in the medical research community, to both advocate for vaccine development and policy. She joined Sanofi's vaccine field medical team in June of 2022 and is based in St. Louis and assigned to the Missouri, Kansas, Nebraska, and Arkansas territory. In her role as the medical science liaison, she engages with healthcare professionals to discuss vaccine immunization-related science, policy, and medicine. So we are super grateful to have them and excited. And with that, I will turn it over to Dr. Malouf to start us off.
Good afternoon, everyone. If I don't seem like a familiar face to some of you, it's because Dr. Bettinger, I think, has been really involved with KDHE for some time, but she is currently at home on maternity leave with her newest son, Henry. And so she kindly asked me to pinch hit for her. So I'm honored to be here today to talk to all of you. So yeah, next slide, please. So our objectives for today, we'll start with the hepatitis B vaccine, then we'll discuss RSV epidemiology, figure out who are the high-risk groups, track the history of RSV vaccine development, recognize the differences between Synagis, Beyfortus, and Abrysvo, determine eligibility criteria, understand the challenges of the last year's rollout, and then be prepared for this year. Next slide. All right, hepatitis B vaccine. So Jill Nelson kindly gave me a heads up right when this call started that in a week, things will be a little bit different at hospitals, especially if I guess you haven't gotten in touch with Rachel Sample, because there's no CDC will no longer sponsor it. It's going to be sponsored through VFC and private insurance. Is that correct, Jill? Did I say that right?
Yes, it's moving to that.
Okay, thank you. And she says she'll be available for questions if anyone wants to throw out. But getting back to the hepatitis B vaccine and why we even do this. So I think most of us are aware that hepatitis B is an infectious disease, and it's one that we don't always clear. And so it's possible that it stays in you chronically, and that can lead to liver damage, so cirrhosis. And then there's also a concern for liver cancer. So that's a big yucky, right? We want to avoid it if we can. And then I think that third point is really important, that there's no cure for it. And we also know that moms can transfer hepatitis B to their babies. And so that's a little bit scary. So because of all of those reasons, we like to give the hepatitis B vaccine within the first 24 hours of birth. And if we know that mom is Hep B positive, which is screened for prenatally, then you're going to want to give the Hep B vaccine and the Hep B immunoglobulin within 12 hours of birth to prevent transmission. And then for those kiddos who are born to moms that we know had hepatitis B at delivery, then at usually around their first birthday, somewhere between 9 and 12 months, you're going to get the hepatitis B antigen levels and antibody levels. So the hepatitis B antigen is to see if the baby is infected, and the hepatitis B antibody is to make sure that they have a good response to the primary series, which ends at 6 months of age. Okay, thank you. Next slide. All right, now can you click a second click? Yeah, I don't know why I did that, sorry. So RSV by the numbers. So this is just establishing that this is also yucky. For any of you who have worked at Children's Mercy, you might be aware that in the wintertime, they actually usually had like a different color team, like I think maybe silver team, dedicated just to RSV because there was so many admissions for RSV or bronchiolitis in general. When we look at the numbers, it's pretty impressive how many hospitalizations were just in the US, and this is 2021 data, but 58,000 to 80,000, but worldwide 3.6 million. And then the deaths per year, gratefully, in the US, due to the resources, 100 to 500. So it wasn't significantly high mortality as compared to the number of hospitalization, because we have a lot of good supportive treatments to support kids through the illness, but over internationally, more than 100,000 deaths. So again, just a pivotal illness historically. We know that 20 to 30%, so up to a third of infants who contract this illness will develop lower respiratory tract infection. That's the RTI. So as opposed to just being like an upper respiratory infection where they're just like snotty and you're suctioning every 5 seconds and losing your mind, this is when they go on to develop the bronchiolitis or the pneumonia. And when it's in the lower respiratory tract, when we're having difficulty with breathing, having desaturations in oxygen, that's when kiddos also tend to not be able to feed very well. They get dehydrated. And these are the kind of things, either respiratory distress or dehydration, that tend to lead to hospitalization. So what is it? Respiratory syncytial virus. Hopefully I said the second word right. It's a virus that, as I just said, usually causes more like mild URI symptoms. Probably everyone here has had it. You just wouldn't necessarily name it because it didn't matter much to you because you're like, oh, I have the common cold. Unfortunately, for the higher risk groups, as I just said, it can be more than a common cold. It can be that lower respiratory tract infection with significant morbidity and mortality, as we've already seen. So older adults are a risk group, and we see that, right? Like everyone's probably seen those like Arexvy TV ads during the Super Bowl and stuff. And so we're trying to get the two highest age groups targeted for these immunoglobulins / vaccines. And that's the older age group. And then of course, the younger age group, the infants. Specifically former premature babies, those with chronic lung disease, chronic congenital heart disease, and neuromuscular diseases. So think inability to clear secretions were at higher risk for the morbidity and mortality we just discussed. Okay. So this was really interesting to me. Dr. Bettinger kindly set up like an outline for what she thought would be most useful to this group. And so I got to have the pleasure of looking into the early RSV vaccine development. And I realized why they didn't pursue it, because initially it didn't go very well, to put it mildly. In fact, when the first targeted vaccine trials actually primed kids for more significant disease. And so there was 2 deaths and an 80% hospitalization rate. Like that's just absurd, right? Like when we said that like 20 to 30% of infants would have lower respiratory tract infection, the fact that like 80% of the kiddos had severe disease scared a bunch of people off. And so there was less interest in trying to develop a vaccine when they figured they were causing more harm than good. But then in 1998, palivizumab or Synagis was created, a monoclonal antibody. And so anybody who's worked in the NICU or with extreme premature infants are probably familiar with Synagis. It was the best we had, but it wasn't great. So it was really costly, and it required monthly immunizations, or I guess it's technically a monoclonal antibody, but monthly injections, we'll say, throughout the RSV season. So from November through March, parents of these extreme preemies and other high-risk groups were bringing their babies in every month to get an injection to prevent severe disease. And those outcome measures were really like hospitalization, death, etc. And so it wasn't to say that they weren't going to get it. The hope was it just wouldn't be severe enough to cause complications. And so that's why only high-risk groups were targeted, because it wasn't super effective. It really only limited the severe disease, and it required a monthly injection on top of its high cost. Next slide, please. Okay. And then last year, everything changed. It was like a hallelujah moment, right? So it's still a monoclonal antibody that we give directly to kiddos. So when we say vaccines, it's a bit of a misnomer. The next one, Abrysvo, is truly a vaccine, but Beyfortus is a monoclonal antibody, and it's also called nirsevimab, which hopefully hopefully close. I like to call it Beyfortus because I know that I'm saying that right, or I think I am at least. I think the impressive stat on this one is that it blocks antibodies 50-fold time greater than Synagis. So if we're saying that Synagis is pretty wimpy, then Beyfortus is the opposite. It's pretty strong. And in clinical trials, again, there's it depends on where you look, anywhere between 70 to 80%, but 77% seem to be a common number. Reduction in hospitalization of RSV and it was 80% effective greater than 150 days out. Why is this important? Do you remember what we were just talking about with Synagis? I realize I'm like asking myself the question, but we'll assume it's rhetorical. If we just remember what we just said with Synagis, it was required those monthly injections. So it's really awesome that not only is Beyfortus like a super powerful, strong monoclonal, but on top of that, it lasts throughout the season that we're concerned for, the most at-risk season. So this one, again, is the one that you give directly to the newborn or the infant. Let's contrast that with Abrysvo. So that one is reliant on the mother. So during the third trimester of pregnancy, a mom will get the vaccine, Abrysvo, and that will give passive antibody protection to the newborn infant. And it was also found to be really effective, with 85% reduction in RSV visits and a 92%, you know, like we're getting A's now, 92% reduction in severe RSV illness. So everything that came out last year was pretty impressive. Next slide, please. And that little baby's so cute. Okay, so continuing on, how were you eligible? So for Abrysvo, again, it's for pregnant women in the 32 to 36 week of gestation. That was specifically because there was concerns that there wasn't, the p-value was found to be insignificant, but there was some concern that there was an uptick in preterm labor in women who got Abrysvo, and so they wanted to wait as long as possible. It looks like the post data, that's not going to hold up, but that's where that recommendation originally came from. And this is a seasonal vaccine. So like last year, mamas who were pregnant, if like they became pregnant after January, they weren't getting the vaccine. I didn't say that. I said that very confusingly. The point is you can only get it September through January. Think seasonal like a flu vaccine. And that's because we want to make sure that the baby has that. Remember how we said, like, we're trying to get them through the RSV season. And so the concern is that those antibodies won't still be protective if we do it too long after. And this really coincides beautifully with Beyfortus, which again, the monoclonal we give straight to the infants or newborns. And it's approved for kiddos that are 8 months or younger. It's also seasonal, so we give it October to March. My understanding at KU is we're starting October 1st. And this is for moms who we either don't know if they received Abrysvo. This is for babies of moms who either don't know if they received Abrysvo or if they received it less than 2 weeks before the birth of the baby, because then it's presumed that they didn't get enough of the antibody transfer. So what does that look like clinically? That means a lot of the kiddos don't even need Beyfortus. Like there's that really significant overlap where if mom did get Abrysvo greater than 2 weeks before the baby is born, then the baby doesn't need Beyfortus. However, you can see how, like, depending on seasonality, etc., the baby would need Beyfortus, or if mom had decided not to get Abrysvo, because when you think about it, the plan is actually not to protect mom, right? The reason why she's getting because she's not high risk for severe disease. She's probably going to get like just a common cold if she contracts RSV. But the reason why she's getting the vaccine is to protect the infant. And some people might not want to do that. They might be hesitant to get the vaccine and prefer to just get the monoclonal for the baby after birth. So that's something to consider. The high-risk groups for second dose of Beyfortus, so that means in a second season. So this is the babies that are 8 to 19 months, include American Indian, Alaskan Native, kiddos with chronic lung disease of prematurity. And I left 3 dots because it's not that simple. It's more like if they have severe disease, if they'd had a recent hospitalization, etc. Those with severe immunocompromise and severe cystic fibrosis. So pretty limited group who are eligible for that, basically their second year of life getting a second dose of Beyfortus, because again, at that age, they're less at risk for severe disease. Next slide, please. So last year, well, in a way, beautiful, right? Because we had these new tools that we never had before since the 1998. We only had Synagis, and that was only for those really, really high-risk babies. But also a bit crazy. So in May of 2023, Abrysvo received FDA approval, so the vaccine for mamas. And then quickly following that, in July 2023, Beyfortus received FDA approval. And so that wasn't a long time frame to get things going. As soon as they received like CDC approval and all that kind of jazz, insurers, the VFC, or like basically Medicaid, but it's not. But anyways, so the government, I'll say the government run vaccine program for children, that's probably the best way to say it, immediately covered, but private payers had up to a year to cover. But that wasn't really even the biggest problem. It wasn't the payer option. The biggest problem was just getting enough product in the hands of people who needed it. So I think you probably saw that there was a bit of like calling your pediatrician's office to see if they got any doses. A lot of private practices didn't get any. Hospitals had better purchasing power. So AKU, we were pretty lucky and got quite a few doses, and were able to start immediately immunizing newborns at birth. And then we were also giving the Beyfortus in the clinic for babies who hadn't gotten it at birth, or if their moms hadn't gotten Abrysvo. But even at that, we really just had the lower dose. So there's 2 doses, and I think that, yeah, that's on a next slide. So even at that, we were really only with that lower dose, and at 5 kilos is the cutoff, and most babies are about 5 kilos by 1 month of life. And so babies who were like 4 months old were coming in, and their mamas and daddies were asking, okay, can we get the Beyfortus? We heard this really great RSV protective vaccine out there now. And like, sorry, we don't have that one. And so that was difficult and sad. So hopefully this year will be different. And then to like lead myself in perfectly to the next slide, that's where it shows those 2 doses available. So less than 5 kilos is 50 milligram dose, and greater than 5 kilos is 100 milligram dose. And again, the one we were really short on last year was the 100 milligram dose, at least at KU. And then again, yes, newborns can receive Beyfortus at birth in the hospital. And there's really like, in my opinion, that last year there really wasn't a contraindication, because like the only like true contraindication was like a previous reaction to Beyfortus, and I just didn't know how a newborn infant could have already had a reaction to it. But in coming years, it makes sense that that would be a contraindication. Okay, next slide. So leading into to our next talk, you can see the who makes it. And then the post data was just as impressive, if not more, than the pre-data, the clinical trial data. So CDC said that it was 90% effective at preventing hospitalization. Sorry, I should say preventing hospitalization. And then, so that's really, really good news. Again, we're getting the A, and that was better than that 77% or something that I told you in a previous slide. And then in July of 2024, CDC said they didn't anticipate any changes to the RSV schedule for infants and pregnant women, although there are a couple of changes to the senior adults, but that doesn't really impact us. Okay, so I went through all of that quickly, so I understand if there's any questions, and I will do my best to answer them. Okay. If you come up with anything, feel free to add it into the chat or ask later, whatever feels best to any of you. Do we have good buy-in from local hospitals? Can I have more context? The peds offices didn't have doses. So last year, yes, I agree. I think that it will be different this year because they had an entire season to make a lot more of it. And that's probably what we're going to hear about in our next presentation. Would you agree with that? Yeah. So that's the hope, that like last year, again, there just wasn't a lot of time to ramp up production before RSV season was upon us after approval. And so the expectation is that we will have enough this year. So thank you for that
The
question.
most part, do you think that the goal would be for most infants to be getting this at the birth hospital and not on the peds offices? Is that what I'm understanding?
I mean, it'd be great if they could. Yeah, I mean, it's not bad. It just, again, it just depends on like when they're born, if it's possible or not. So like if they're born in that like October,
In the season, yeah.
yeah. So it just depends on if it's in the season or not. And then also like if it's the second round, then they, like if it's a high risk kiddo in the second season, then of course they'll be getting it at clinic too. So having that 100 milligram dose, I think, is what probably more needed in the outpatient setting. But of course, you need both overall. And some parents might just be hesitant to get it in the hospital setting. It might be a provider they're not familiar with, et cetera, and they might feel more comfortable getting it in their provider's office with someone that they already have rapport and a trust relationship from. Last year, we were giving a lot of them at 4-week visit, and that's just because that's when it was available. So like the kids who were born, the month before could now get it in the clinic setting. Does that make sense?
Absolutely. Thank you.
Yeah.
And then Dr. Maloof, will you stay on through the rest of the presentation? And then if there are more questions at the end, we can take those again then.
Okay, great. Thank you, everyone.
right.
Appreciate your time.
Thank you. And Heli, I have stopped sharing. If you want to share your screen, you can go ahead and go.
Yeah, thanks so much. So thank you so much for letting me be on this call. My name is Heli Hassas, as mentioned already. I will also address some questions that came up regarding supply and some of the hospital settings, maybe towards the end of the presentation as well, just so you are assured that we are working really hard to have supply that's needed for every infant to be protected. So I want to first start out with my Beyfortus experience. So this is my little nephew who was born last year, and he was probably one of the first few infants that received Beyfortus. And that's me visiting him in May of this year, and he will be almost 1 year old. So he's doing really great, had no significant RSV infection. All right, so now moving on to the presentation. And some of this information might be a little bit repetitious from Dr. Maloof's presentation, but there's this principle of repetition. I'm not sure if you're familiar with it, but it says that you have to repeat something 3 times to help people understand or remember it. And so hopefully by having a few things that are repetitious, you'll be able to recall this much better. All right, so RSV, as we know, is a common cause of lower respiratory tract infection in infant and is actually the leading cause of hospitalization in the US. The highest RSV hospitalizations occur in the first few months of life, and then the risk declines with increasing age in early childhood. In this pyramid, some of these numbers Dr. Maloof already mentioned, so I'm not going to go too much into detail, but one key point is that about 1/3 of RSV infection in the first year of life lead to lower respiratory tract infection. So a really significant number and causing a burden inpatient as well as outpatient, right? So this data in this slide comes from a study that was done by Ariola. In the study, they attempted to identify the population of infants that is hospitalized with RSV. And now you see, RSV all the time, so this data might not surprise you, but they found that 72% of infants hospitalized for RSV were healthy term babies. And so it's really fundamental, in the challenge of addressing this disease, because these infants had no underlying conditions, no risk factors, and they were not preterm either. So kind of hard to predict, right, which infant will end up in the hospital after an RSV infection. And then, we have the complication of seasonality. So RSV is a seasonal virus. Prior to the pandemic, it had a pretty regular pattern. It started in October and then peaked in, December, January, February, and then trailed off towards March. And as you can see here in this graph, during the pandemic, when everyone was staying home and staying away from all kinds of activities, there was no RSV seen. And then coming out of the pandemic, we saw some odd patterns. There was the peak in this, like the occurrence in the summer, the really, really high peak in 22, 23. And then 23, 24 seems to be kind of returning back to the normal seasonality of RSV. So we'll see what happens this year, but it seems to be trending back toward the normal season. So RSV is a virus that has 11 proteins, and it actually circulates as 2 serotypes. So you may have heard RSV-A and RSV-B. And it lasts, typical RSV season lasts about 5 months each winter in temperate climates. So there are 2 proteins that are important on the RSV virus surface. We have the G protein and the F protein. And the F protein is present in 2 kinds of conformations. It's the prefusion and a postfusion form. And then the G protein is actually what helps the virus attach to the host cell. So this is kind of how the virus, gets into our cells. So nirsevimab binds to the prefusion form of the F protein. And so if you block that protein, you block entry into the host cell. All right, so this kind of depicts antibodies that target that prefusion conformation of the RSV F protein are the most potent. If you remember or recall from Dr. Malouf's presentation, nirsevimab, as she mentioned, is over 50-fold stronger in affinity than Synagis. So this kind of shows you why that is. It's because it only targets the prefusion conformation. All right, some more details on nirsevimab. It's an IgG kappa monoclonal antibody, targets site 0, if that's important to anyone, but I can tell you more about it if you have questions on that. One key point on this slide is that this monoclonal antibody has an extended half-life. So it was engineered to contain 3 changes in a specific region, so that makes it have an extended half-life so that the baby is protected for that complete 5 months of the RSV season. All right, and as we know, there are 2 approaches to RSV protection for infants. There is the maternal RSV vaccination, as well as the infant nirsevimab administration. So, some advantages and disadvantages of both approaches. I'll start with the infant nirsevimab here. So advantages there are that the antibody levels suggest that protection might wane slowly because of that extended half-life with the modification of the antibody. And then an additional advantage is that we are not relying on the mom to have antibodies transferred to the infant. Infant will be given the antibodies so that they are ready to, have the protection that they need when they are exposed to RSV. A disadvantage, of course, this requires an infant injection. This might be a disadvantage for some parents who, are already maybe hesitant that their infant is getting so many vaccinations or injections. So one thing to consider there. Then moving on to the maternal vaccination, advantages, of course, also, the point is to protect the baby, so provides protection immediately after birth. This strategy might be more resistant to potential mutations in the F protein. So remember, in the maternal immunization, antibodies it's kind of like a polyclonal kind of response. In the nirsevimab, it's a monoclonal antibody. So sometimes that lends itself to mutations in the F protein, which can be a disadvantage of the nirsevimab monoclonal antibody. Disadvantages for maternal immunization, protection potentially is reduced if not enough antibodies are transferred, depending on mom's condition, if they're immune compromised, or if the baby is born less than that 14-day period before, full transfer of antibodies can take place. Seasonality is also key, right? As we mentioned, RSV circulates, let's say, November through March. So if an infant is born sometime in April, maternal immunization in April will not help the baby with protection when RSV season occurs. So in that case, you would be giving the infant nirsevimab at the start or shortly before the start of RSV season. Then babies, kind of going through that graphic here, babies born in July may have some protection from maternal immunization, but also maternal immunization assumes full efficacy of about 3 months, and then a lower efficacy for an additional 3 months. So you can see that nirsevimab administered for babies that are born before RSV season, right at the start of RSV season, and then babies that are born during the season would ideally get it in the hospital. But if that is not an option, then they would receive it within about a week of leaving the hospital with their pediatrician. This is another way to look at it. For the sake of time, I'll move on to some clinical trials. The reason I want to spend a little bit of time here is that the data that we collected in the pivotal clinical trials actually is really reflected in what has been seen in real-world data from last season. I will quickly breeze through these so we have enough time at the end for question, but there were this phase 3 MELODY clinical trial. This trial evaluated safety and efficacy of nirsevimab in healthy late preterm and term infants born at or greater than 35 weeks of gestation, and this was conducted during the 2019-2020 RSV season. The original plan was to enroll 3,000 babies in the Northern Hemisphere as well as Southern Hemisphere. There was a bit of a hiccup in this clinical trial with the onset of the pandemic, and the trial had to be stopped because there was no RSV. Remember when we talked about that earlier? But after this clinical trial resumed again in 2021, and then enrollment was also completed with the full 3,000 intended cohort of infants. So some of those results from that clinical trial, as you can see here, the nirsevimab demonstrated efficacy in reducing medically attended RSV, lower respiratory tract infection, 75%, so 74.5%, and then reduction in hospitalization was 76.8%. So similar to the numbers that Dr. Maloof had already mentioned. The phase 2b clinical trial looked at lower respiratory tract infection in infants that were 29 to less than 35 weeks gestation. Again, similar efficacy when you're looking at medically attended visits as well as hospitalization. So safety of nirsevimab, their most common reaction compared to placebo was rash and injection site reaction. So since this is a monoclonal antibody, we are giving the infant the protection. You are not seeing, that the infant doesn't have to mount a response like with a traditional vaccine. So you're not seeing a lot of adverse reactions. So the most common, again, was rash and injection site reaction. And so now the most exciting part, some real world evidence that I wanted to share with you. Really wanting to see, it's all well and good if you, demonstrate efficacy in clinical trials, but then how does it look like in the real world when it is being administered to all infants, right? So real world evidence, demonstrates if a treatment or immunization is effective in day-to-day practice, right? As opposed to efficacy, which determines efficacy in controlled clinical trials. So we have in red, the Harmony clinical trial. This was, the Harmony data. It's a clinical trial, but it demonstrates real world effectiveness. That was in UK, France, and Germany. And then in the purple, we have some data from CDC through the NVSN network, as well as a lot of data from Europe, so Spain and France in particular. And then we also have some population impact data, which is there in the green. And this Harmony clinical trial was a real-world clinical trial. It enrolled infants born greater than or equal to 29 weeks of gestation. This was done in France, Germany, and UK. Again, looking at the efficacy data there for hospitalization, 83.2%, severe RSV was 75.7%. You will see kind of a pattern in these next few slides that the effectiveness, or the efficacy that we had seen in the clinical trials is reflected in what we have seen in the real world. Similar to the efficacy, safety also is obviously very important. We have data regarding safety that matches up really well with what was seen in clinical trials. So really well tolerated and no adverse or very, limited adverse events that we had to take a look at here. Every, study has their limitations, and here are some listed for the Harmony clinical trial. And this data was really exciting. This was presented actually at the most recent ACIP meeting. So this is the new vaccine surveillance network data. This looked at infants less than 8 months. So they were given nirsevimab October 1st, 2023, or born after. And they were looking at hospitalization in the US. So this was conducted in Houston, Texas, Nashville, Tennessee, Pittsburgh, and then Seattle. And as you can see here, 90% effectiveness for preventing hospitalization. And there were about 700 infants enrolled in this clinical trial. Limitations as well, I'll go over these quickly. And then the data that's coming from Galicia, Spain. Galicia, Spain was one of the first countries in Europe that adopted nirsevimab for all their infants. This was, they have a healthcare system that provides Beyfortus free of charge to all of their infants. And so we were able to collect data from this retrospective cohort study, again, paying attention to the effectiveness of 82% in hospitalization, and then 86.9% for severe RSV, lower respiratory tract infection with oxygen support. Safety, again, in line with clinical trials, as well as, what we have seen so far in the real world. This kind of summarizes the real world studies that we have accumulated so far. Again, everywhere you look, it's between, 75 to 90% effectiveness of nirsevimab. Notice the Luxembourg, it says 69%. They designed their study a little bit different. They were looking at RSV hospitalization reduction compared to previous years. So their design was just a little bit different and not looking at effectiveness. All right, implementation. Some of this was covered by Dr. Malouf, but I will maybe just quickly go through these. These are the 2 dosage forms that are available for nirsevimab or Beyfortus. They're refrigerated at 2 to 8. One key point on this slide is that this can be administered at the same time as all the other infant immunization that the infant would be getting at those visits with the pediatrician. So you can give those at the same time. Here again, in the first RSV season, so infants, that are born during this RSV season would probably be less than 5 kilos, so they would be getting 50 milligrams IM, and then infants that are 5 kilograms or greater, they would be receiving 100 milligrams. That second RSV season is for those very high-risk infants that are at increased risk for severe RSV disease. Think of those infants as those infants that would typically have received palivizumab or Synagis also. And those infants in their second season would be getting 200 milligrams, given as 2 separate IM injections. ACIP recommendations here listed for you. Again, the only added on this slide is that American Indian and Alaska Native children are considered at increased risk in their second season. So they would actually be getting first season and second season protection. So that's something to note there. Also, nirsevimab has been added to the Vaccines for Children's program. So one of the key messages here is that a lot of hospitals are probably, nationwide, not VFC providers. So there's a really great, benefit to becoming VFC providers for hospital systems so that they can take advantage of administering nirsevimab in the hospital for VFC babies. Here are the AAP recommendations. They are the same as the ACIP recommendations that I just showed you. This kind of graph shows you the implementation strategy. So infants born outside of RSV season would be receiving it typically beginning of October, so October 1st. And it would nirsevimab would be administered all the way through the end of March. So March 31st is kind of the cutoff. All right. One point I wanted to make about the importance of administration of nirsevimab in the hospital is that approximately 1 in 8 commercially insured and 1 in 4 Medicaid insured do not have an outpatient visit within 5 days of birth hospitalization. So, kind of key to remember this kind of in the back of your mind if your hospital is not administering Beyfortus at birth, is this statistic that there are infants that are going to be missed this opportunity to receive protection for RSV. Also wanted to make you aware that it's important to counsel your pregnant moms on both of these options. So the option of receiving maternal immunization, but then also knowing that there is an infant protection available to them as well. So CDC and ACIP have the statement regarding counseling of pregnant persons about those 2 options. So quickly going over some of the criteria for nirsevimab administration when maternal immunization is also available. So children 8 months less than 8 months of age should receive nirsevimab just before or during the season if, so there's the few ifs. The mother did not receive RSV vaccine during pregnancy. The mother's RSV vaccination status is unknown. The infant was born within 14 days of maternal RSV vaccination, right? Infant did not have enough time to get those antibodies from mom. And then even if maternal immunization was administered greater than 14 days before delivery, if clinical concern regarding antibody transfer or risk exists. So there are some times when clinician judgment is really key to making those decisions for the infant, whether they should receive nirsevimab or not. All right, I think this is almost my last slide. This is just a statement also in collaboration with CDC and American College of Gynecology, really stating that patients should be counseled on both these options so that they can make an informed decision on which option they want to choose and what's best for their family. And before I open it up to questions, I am always open to feedback and advice. If you can quickly take a picture of this QR code and answer a few questions for me, this is just to help training and also just giving me some feedback on what I can do better. So I'll leave that up for just a second and then we can open it to questions. And I did not pay attention to the chat, so maybe as we are thinking of some questions, I can start with, obviously, we had challenges with the supply last season. Be resting assured that we are working very hard. We had new facilities added for production that were just recently FDA approved. And so, you know, if there are any issues that you have with getting the supply that you need, please let us know. We have a whole commercial team that is working on getting you the doses that you need. I'd be happy to, you know, if you reach out to me, let you know who your contact person is going to be for that. But please feel free to get in touch with me anytime.
Okay, well, if you guys have any questions, this is a great opportunity to do so. You can pop them in the chat or come on mute, whichever way works best for you. We can also send any questions if you have any. If you think of after the fact, let us know. We can send those off to either of our speakers today.
As you guys are thinking about questions, I wanted to share some resources with you that have been really helpful actually in deciding kind of how to use nirsevimab. So this is a AAP visual guide to using nirsevimab or nirsevimab administration. Kind of guides you through the different pathways of how you would make a decision on what to give. Gives you the dosages. And then what I really like down here, it gives you the criteria of infants or children that are 8 to 19 months and those high-risk criteria, as well as giving that, you know, clinician judgment for when it's might be still necessary to give nirsevimab, even if mom has received maternal immunization.
Sorry to interrupt. Sorry to
yeah.
interrupt, Eli.
Mhm.
Tiffany, did you just unshare? Okay, perfect. Sorry, I
Do you
switched
see her
over.
screen?
I can see it because I'd switched over, but can someone pop in the chat if you're able to see? I can't see either screen now. Here we go. I can
Okay,
see
perfect.
hers.
Thank you.
So I'll pop this
Perfect.
in I'll pop the link to this in the chat so you have this. It's really great to print out and kind of have at your disposal. One other resource from CDC is this options for infant RSV protection at a glance. What I really like about this one is the second page kind of comparing the two side by side and, you know, some of the differences that exist between the two. So also really great resource to have on hand when you are learning about this or making decisions for administration.
Those are great resources. Thank you so much for those.
Yeah.
Would you be able to email both of those to me as well? And then that way we can send them out with the slides after. That would be great. Thank you so much.
Absolutely.
Well, if there's no other questions, both Heli and Dr. Maloof, thank you both so much for speaking today and taking the time out. We really, really appreciate it. And I just want to send one last reminder out. If you haven't registered for October 22nd, just remember it's a free registration, and then it is virtual too. So we'd love to see everyone at our October conference. There is a question in the chat asking, is there still a time when Synagis is still appropriate, or will that vaccine become more obsolete now?
Yeah, that's a great question. So I believe that most health systems, if nirsevimab is available to them, will choose to give nirsevimab. That might be, you know, a cost issue too, because Synagis has to be administered, you know, consecutively every month in the season. So if you have nirsevimab available, the AAP and ACIP recommends that you give nirsevimab over palivizumab.
Perfect. Great question, Stephanie. Any others out there? Okay, well, we'll give everyone back just a few minutes of their day, and thank you so much again for speaking, and thank you all for joining, and we hope you have a great rest of your week.